You are not a nervous person. You never used to be. But something shifted. And now your heart races for no reason. Your mind won't stop. You lie awake at 2 a.m. with a sense of dread you cannot name. Your hands tingle. You feel short of breath sitting still. You feel, on some days, like something is genuinely wrong. But every test comes back fine. And everyone around you says it is probably just stress. What if it is not stress? What if it is a vitamin your body stopped absorbing years ago and nobody checked? Vitamin B12 does not get discussed the way other deficiencies do. It does not have the cultural visibility of vitamin D or the dietary conversation of iron. Most people assume they get enough from food. Most people assume that if something were seriously wrong, a doctor would have caught it. But B12 deficiency is significantly more common than most people realize, affecting an estimated 6% of adults under 60 and nearly 20% of adults over 60. And its most disorienting symptom, the one that sends people to therapists, to cardiologists, to sleep specialists, to neurologists, is a constellation of sensations that maps almost perfectly onto an anxiety disorder. Heart palpitations, a racing or irregular heartbeat at rest, a crawling electric sensation under the skin, shortness of breath without exertion, a persistent feeling of internal vibration or trembling, pins and needles in the hands and feet, dizziness that comes and goes without obvious cause, a mental restlessness that is not quite worry, but feels like the body is permanently braced for something. These are textbook anxiety symptoms. They are also textbook B12 deficiency symptoms. And the distinction matters enormously, because one responds to therapy and medication targeting the nervous system, and the other responds to a supplement that costs almost nothing. To understand why B12 deficiency produces this picture, you have to understand what B12 actually does. B12 is essential for the production of myelin, the protective sheath that wraps around nerve fibers and allows electrical signals to travel cleanly and quickly from the brain to the rest of the body. Without adequate myelin, nerve signals do not travel correctly. They misfire. They leak. They produce sensations in the body that have no external cause, because the nerve itself is generating false signals from a degraded infrastructure. This is called subacute combined degeneration of the spinal cord in its severe form. But long before it reaches that stage, the early myelin damage produces something subtler, a nervous system that is running on degraded wiring. The signals that should communicate calm, normal body function become noisy, irregular. The body interprets that neural noise as threat. The result is an internal alarm state that feels exactly like anxiety. Because, at the neurological level, the mechanisms overlap. B12 is also required for the synthesis of SAMe, S-adenosylmethionine, a compound involved in the production of serotonin, dopamine, and norepinephrine. Without adequate B12, neurotransmitter synthesis is impaired. Serotonin falls. Norepinephrine dysregulates. The nervous system loses its chemical buffer against perceived threat. A person who was previously resilient begins to feel chronically on edge, not because their life circumstances changed, but because the neurochemical floor dropped beneath them. The palpitations deserve particular attention because they are the symptom most likely to send someone to a cardiologist, and most likely to come back with a normal cardiac workup. B12 deficiency causes elevated homocysteine, an amino acid that accumulates in the blood when B12 is insufficient because B12 is required to convert it into methionine. Elevated homocysteine is independently toxic to blood vessel walls and to cardiac conduction tissue, the specialized cells that regulate the heart's electrical rhythm. As homocysteine rises, the electrical system of the heart becomes irritable. Ectopic beats appear. The heart fires out of sequence. The person feels this as palpitations, a skipped beat, a sudden thud in the chest, or a racing sensation that comes out of nowhere and resolves in seconds. The cardiac workup is normal because the heart muscle itself is structurally fine. The problem is chemical. The ECG does not show homocysteine elevation. It shows the rhythm. And if the rhythm happens to be normal during the recording, which it often is, given that palpitations are intermittent, the cardiologist sees nothing, orders nothing further, and the patient is told their heart is fine. The homocysteine level is rarely tested. It costs almost nothing to measure, and correcting B12, along with folate and B6, which work in the same methylation pathway, reduces homocysteine reliably and significantly. There is a reason B12 deficiency is so frequently missed, and it is not simply oversight. The standard serum B12 test measures total B12 in the blood, but not how much of it is functionally available to the cells. B12 circulates in two forms, active and inactive. The inactive form is bound to a protein called haptocorin and cannot be used by cells. The active form, holotranscobalamin, is what actually enters cells and performs B12's functions. A person can have a serum B12 that appears within normal range while their active B12 is critically low. The total looks acceptable. The functional level is not. This is why symptoms can be present and severe, while the standard test shows nothing actionable. The more sensitive markers are holotranscobalamin, the active fraction, and methylmalonic acid. Methylmalonic acid is a compound that accumulates in the cells when B12 is functionally insufficient. It is a direct cellular readout of B12 activity, not just blood concentration. Elevated methylmalonic acid in the presence of a normal serum B12 confirms functional deficiency. The body does not have enough active B12 to clear it. This is the test that catches what the standard measurement misses. Absorption is the other piece most people are never told. B12 is absorbed through a highly specific mechanism. In the stomach, a protein called intrinsic factor, produced by the stomach lining, binds to B12 and carries it to the small intestine for absorption. Without intrinsic factor, dietary B12 cannot be absorbed regardless of how much is consumed. Intrinsic factor production declines naturally with age, which is why B12 deficiency is so much more prevalent in older adults, even those eating B12-rich diets. Proton pump inhibitors, the acid-suppressing medications taken by millions for reflux and heartburn, reduce stomach acid, which is required for releasing B12 from food before intrinsic factor can bind it. Metformin, the most commonly prescribed diabetes medication in the world, directly impairs B12 absorption in the intestine and is estimated to cause deficiency in 10 to 30% of long-term users. Chronic gastritis, Helicobacter pylori infection, and celiac disease all damage the stomach and intestinal lining and reduce absorption capacity. This means a person eating meat, eggs, and dairy every day, foods rich in B12, can develop significant deficiency if their absorption pathway is compromised. The dietary intake is irrelevant when the mechanism to absorb it is broken. The most important thing to understand about B12 deficiency and the anxiety it mimics is the timeline of neurological damage. Myelin damage from B12 deficiency accumulates over months and years before symptoms become diagnostically obvious. The tingling, the palpitations, the dread, the mental restlessness. These begin in the early phase of neurological involvement. At this stage, the damage is reversible. B12 repletion stops the progression and allows remyelination to begin. But B12 deficiency is one of the few nutritional deficiencies where delayed treatment produces permanent neurological consequences. If myelin damage progresses to the stage of subacute combined degeneration, affecting the posterior and lateral columns of the spinal cord, some of that damage cannot be fully reversed, even with aggressive treatment. The window matters. The earlier deficiency is identified and corrected, the more completely the nervous system recovers. This is why a person with anxiety symptoms that have not responded fully to standard treatment, or that appeared alongside tingling, fatigue, cognitive slowing, or palpitations, deserves a complete B12 workup, not just a reassurance that the standard serum level is within range. Ask for serum B12 as a starting point, but ask also for holotranscobalamin, the active fraction, and methylmalonic acid. If methylmalonic acid is elevated, functional deficiency is confirmed regardless of what total B12 shows. Check homocysteine. Elevated levels implicate the entire methylation pathway and carry independent cardiovascular risk. Note any medications that impair absorption, PPIs, metformin, H2 blockers, and discuss whether B12 monitoring should be part of ongoing care while taking them. For people with confirmed absorption problems, oral supplementation is often insufficient because the absorption mechanism itself is compromised. Intramuscular B12 injections bypass the gut entirely and deliver the vitamin directly into circulation. In patients with severe deficiency or neurological involvement, injections are the standard of care, not a high-dose oral supplement. The symptom that looks exactly like anxiety is not always anxiety. Sometimes it is a nervous system running on depleted infrastructure, misfiring on degraded wiring, producing an internal alarm state from a chemical deficit that has been building quietly for years. The the dread you cannot name, the heart that races at rest, the hands that tingle at 2 a.m., the feeling that something is wrong when nothing, on paper, is wrong. Get the full panel. Know the difference between serum B12 and active B12. Ask about methylmalonic acid, because the answer to years of unexplained anxiety might be an injection, not a diagnosis.